Hello, and welcome to today's webinar, Understanding Medicare and CLL, What Patients Need to Know. I am Liza Avrick, Program Director at CLL Society. This program is made possible through generous donors like you and our Policy Institute supporters, AstraZeneca, Bay One, and Genentech. At this time, I would like to welcome our speaker, Saira Sultan. Thank you.
Welcome to the webinar. I'd also like to include and introduce my colleague, Kay Scanlan. Kay and I have worked together for a number of years. She is the principal at Concilium Strategies. Kay will be helping me monitor the Q&A and answer questions, and she'll chime in as appropriate for filling in on anything I may have missed on these slides as we go forward. Our learning objectives today, we hope you will take away an understanding of the different parts of the Medicare program and what each of them includes. We'll spend a few minutes talking about original or traditional Medicare and how that differs from Medicare Advantage. And finally, understand the latest updates to Medicare in terms of changes that have come about in 2025 and will come about in 2026. So this is often referred to as the alphabet soup of Medicare. We will try and spend some time today understanding the differences between parts A, B, C, and D. And as we go through these, we'll try to answer your questions. This is just sort of an illustration of the four parts. And we'll also go through what each one will cover for you in your healthcare journey through the system. So we're doing this today in part because open enrollment begins on October 15th, and you will have an opportunity to make these two choices among the other choices you'll make throughout your enrollment effort. The first part will ask you, will give you the opportunity to choose original or traditional Medicare. This gives you part A and B, which is the hospital part. And what I think of B, medical insurance, I often think of it as your physician office or outpatient, so inpatient and outpatient. Part D are your pills and tablets and self-injectables. And Medigap will help you fill in, just as it sounds, the gaps to cover some of the costs that are yours out of pocket through the different parts of Medicare. Medicare Advantage is in some ways one-stop shopping in that it rolls up parts A, B, and D. And together, don't ask me why, we call that C. So part C is not an individual part like A, B, and D. It is really the summation of A, B, and D together when bought together. So there's typically automatic enrollment for parts A and B. So I won't spend much time on this point, except to say that there's a distinction between initial enrollment and open enrollment that we'll cover in just a minute. The initial enrollment begins typically 3 months before you turn 65, and you get your Medicare card and so on and so forth, which is different from open enrollment, which is the annual process for which we have timed this webinar today. Okay, I guess we'll also talk about general enrollment. So this is an enrollment that I think the most important thing to say about this is that that you may incur a penalty if you enroll outside of the initial enrollment period and you were not otherwise covered by, say, an employer plan. So if you were working up until the age of 65 and you were already in a employer plan, or even if you worked through the ages of 66, 67 and had an employer plan, then although you should check with your employer to make sure that it's equitable coverage, there will be no penalty for not enrolling in a Medicare plan, but otherwise there might be. So it's really important to watch those dates carefully. Okay, we have our first poll question. Why is your Medicare enrollment period why is your Medicare initial enrollment period important? Is it missed enrollment deadlines could result in penalties? It's your first opportunity to enroll in Medicare. When you enroll impacts when your coverage begins, or the last one, all of the above. Okay, it looks like the vast majority of you said all of the above. And some chose one of the other answers. So the correct answer is yes, all of the above. Missed enrollment deadlines can result in penalties. That is true. And so we want to be especially mindful of your open enrollment period now. And of course, initial enrollment period, as I said a moment ago, means it's your first opportunity, as opposed to open enrollment, which is annual. Okay, so without getting into too many details around hospital services and supplies and rehab and mental health, I'm going to stick to the big picture here. Part A is essentially your hospital insurance, and it's inpatient hospital care, inpatient skilled nursing facility care. So imagine even if you went to an emergency room, if you, for whatever reason, and you had to spend the night, spend a couple of nights, you will sometimes hear people say, we're shifting you to the inpatient floor. That inpatient floor you move to, that is what is covered by Part A. So long as you're staying in the emergency room, you are an outpatient, which we'll cover on the next slide. Or you went in for some sort of a procedure that will require you to be in the hospital for multiple days. Often now you see people are in and out of a hospital for a procedure very quickly, same day, next day. That may often stay an outpatient. Do you need to sign up for a Part A plan? So we are doing this slide after every part of Part A, Part B, et cetera, so that people understand the decision they need to make. So this is free for most people because you've already participated in the program during your working years. Again, there may be a penalty here if you delay. And if you're actively already working, as I said earlier, for an employer, you may not need to sign up for Part A yet or now, but otherwise, if you're typical age 65 enrolling in the Medicare program, it's free and you should use it for your hospital inpatient stays. Part B, in contrast, as I've been talking about, even as I was talking about Part A, if you're still in the emergency room or you're going in for a procedure, but you're coming out the same day or the next day, you're going to a doctor's office for a visit, just a regular checkup, all those things are covered as part of your outpatient services. And that is covered under Part B, like boy. So while we said Part A is free to most people, in Part B, you are paying a monthly premium. And that premium is dependent on your income 2 years earlier. You have a standard, so your premium is what you buy Part B for. Your deductible is what you must meet out of your own pocket before the coverage kicks in to pick up part of the cost. And then the coverage leaves you, once coverage kicks in after you've met your deductible. For the remainder, you pay co-pays and co-insurance, and that is your 20% or $20 or whatever the case may be, depending on the services you're getting. So again, you have to make a decision. Should I keep or sign up or have Part B? Consider that while you do pay a monthly premium, it is typically taken out of your Social Security, and you can use it to supplement your employer coverage, but really you should talk to your benefits administrator to make sure that you're not over-insuring or may not need both at the same time. So Part B, the important thing to know about Part B is that you can buy something called a Medigap policy, which we'll talk about in more detail later, but it will help you offset the costs that you incur out of pocket yourself. And so if you want to have a Medigap policy, you must first have the Part B benefit. If you join a Medicare Advantage plan, Part B will be part of your Medicare Advantage plan. And that way you're not using traditional Medicare, you're using a outside insurer like Aetna, United, et cetera. And you're buying your Medicare Advantage plan, which will include Part B from them. And again, I want to highlight, you may pay a penalty if you sign up late or not in your initial enrollment period. So remember, late doesn't mean not at age 65. It may just be when your employer insurance, it runs out and it's time for you to sign up for Medicare at that point. Okay, just a heads up to Kay. Maybe Kay, I will turn to you for some questions in case any of the questions coming into the Q&A are related to the topics we're talking about now. Otherwise, we'll answer Q&A at the very end, but I see that there are some rolling in, and I'll ask if you could check those while I cover the next slide or two
I
here.
just did. And we do have a couple that are related.
Okay.
If currently on disability and long-term disability, do I need to do something different at age 65? That's certainly related to what we're talking about. And that's an interesting question because you have basically two, you're eligible by virtue of disability, and then later you become eligible by virtue of age. So that presents a situation where, for example, if you've been enrolled in a Medicare Advantage plan, you can switch because you're newly eligible. So you can consider it as almost as if you were newly eligible. If you wish to do that, you could switch from a Medicare Advantage to regular Medicare. You can switch from regular Medicare to Medicare Advantage. You can treat it as an initial enrollment period.
Thanks, Kay.
And then we have a couple others. Not as someone mentioned that they haven't started on their treatment for CLL yet, and they're not sure which drugs are in Part B, which ones are in Part D. If you're getting your drug injected or infused at a hospital, at your clinician's office, it's Part B. If you're eating it or anything that you're administering yourself, that's Part D. So it's pretty easy to be able to tell. If you're at the doctor's office, they give you the medication, it's under Part B. And then let's see, I think we had one. Are there limits on how much Medicare will pay for pharmaceuticals in a patient's lifetime? No. And there aren't limits on how much they pay for drugs in a single year either. The only thing that has a limit is Medicare Part A, the number of inpatient days. There's a limit on that.
So I promised we would get to what is a Medigap policy. These are also.
Oh, Saira, one more thing. Sorry to interrupt.
No, that's okay.
We have a comment to start down, just to slow down just a little bit before switching slides. I think people want to be able to read the slides.
Terrific. Thank you.
Okay.
So a Medigap policy is a policy that you buy from a private insurer, again, like an Aetna or a United or other companies. I think that the important thing about a Medigap policy to understand is that they will help you pay for or help you cover the out-of-pocket costs you're incurring in Part B, like boy, which is why we've injected the slide here while we're talking about Part B. They will not help you cover your out-of-pocket costs in Part D, like David. So to the questioner earlier who asked which of my CLL drugs are B versus D, the distinction is not only important in knowing whether you need you need to be covered under Part B versus under Part D, but also where your out-of-pocket costs will be helped where you'll have some support paying for those out-of-pocket costs and where you won't. The other important thing to know is that Medigap applies when you buy a Medigap policy. It is to help you with your out-of-pocket costs in original Medicare, meaning that you get Part A for free. You contribute, you buy coverage for Part B, like boy, like we just spoke about earlier, and then you have those out-of-pocket costs. It will help with all of that, deductibles, co-insurance, etc. But again, it will not help you with the out-of-pocket costs in Part D, like David. So oral medications like Imbruvica and Calquence and several others. We'll talk about what sort of help you have for paying for those out-of-pocket costs in just a couple minutes. So do you need a Medigap policy? Original Medicare, and we'll talk about this in a bit, costs a bit more than Medicare Advantage. And so if one reason you're not buying an original Medicare plan and going into a Part C or Medicare Advantage plan instead of the original, well, one thing you can do is buy a Medigap policy to help pay for those costs in original Medicare that you have out of pocket. If you have some other kind of supplementary insurance, if you work for the federal government or other things that help with those costs, then maybe you should, compare where you're getting better coverage. If affording deductibles and co-payments is a reason that makes you think twice about Medicare traditional versus Medicare Advantage, then absolutely consider a Medigap policy to see if it fills those concerns.
We had a couple questions. There was one question about the Medigap plans covering the Part B deductible. And it's an interesting issue because there used to be two Medigap plan types, and they're all, labeled by letter. There were two that did cover the deductible. Those are no longer offered for new enrollees. If you have one of those, you can stay in it, you're grandfathered.
Thank you, really helpful. And when is the best time to buy a Medigap policy? Well, you have an open enrollment period that begins the month you're turning 65 and older and enrolled in Part B. The last 6 months minimum, and there may be longer in your own state, so please check. But the important thing to know about a Medigap policy when you first join the Medicare program, companies must sell you a plan. So if you do it later, it may cost you more or you may not get one. So doing this at the very beginning is helpful. And to Kay's earlier point, if you joined Medicare via disability and then turned 65 later, you sort of have an opportunity for a do-over there where you can buy the Medigap policy at that point, and the policy must be sold to you. Okay, another poll question, and I think we've got a couple here. So the first one relates to Medicare Part A. Medicare Part A helps pay for all of the following when medically necessary and requirements are met, except diabetic testing and testing supplies, except an inpatient hospital stay, except an inpatient skilled nursing facility stay, except hospice care. Which of these does Medicare Part A not pay for? And then Part B. In most cases, you, the patient, pays for a monthly premium, a yearly deductible, 20% co-insurance for most covered services, and all of the above. Well, I'm glad to see the webinar is working. The answer to the first one is correct. Diabetic testing supplies are not part of Part A inpatient care. Inpatient hospice, hospice care, inpatient hospital care, inpatient skilled nursing is all covered. Diabetic testing supplies are not. Great. And in the second question, again, that's great. Vast majority of you answered the question correctly, all of the above. So you will have premiums, deductibles, and co-insurance. And we just talked a little bit about the extent to which Medigap policies will help you pay for those things. But yes, you are expected to pay for all of the above. Great, thank you.
Saira, we had a couple questions that I think probably fit here. You did cover whether or not, the enrollment in a Medigap plan. We had a question about, can you be denied a Medigap policy because of pre-existing conditions? And just wanted to clarify that that's exactly what you were talking about. The medical underwriting to be able to say, okay, well, this person is however many years old, they've got these conditions. If you didn't originally sign up for Medigap and you're switching and, et cetera, in many states, they can do medical underwriting. And with medical underwriting, they can deny you coverage or they can charge you more in your premiums. And this is a state, there are a lot of states that have laws requiring guaranteed issue of Medigap plans. So this is going to be a state-by-state basis. The other, it's an interesting question that I don't think are covered in any of the slides. It was about, an individual's husband was taking venetoclax and was getting help, patient assistance from the manufacturer, and wondering whether or not that goes away when you get Medicare coverage. And a good bit of it will, because there are some, I guess you'd call them fraud and abuse issues. We call that generally, but manufacturers have concerns that if they give help to patients, that they'll get in trouble, as if they're giving incentives for somebody, paying people to take their medication. So that's what it looks like to the enforcement side of the federal government programs. So yes, you probably will see that type of assistance go away when you move from commercial insurance to Medicare.
Yeah, and even though we had also solicited questions in advance of the webinar starting, and I was going to answer those at the end, but it's very related to the question we just Kay just posed and answered. So maybe I will do this here. One of the questions we got was for someone who is typically a typical watch and wait patient, and they're 72 years old, meaning they've already been enrolled in the Medicare program or had the opportunity to be since they were 65. 3 years since diagnosis already at the age of 72. And the question is it smart to switch while you're still in watch and wait and 72 years old? Is it smart to switch from Medicare Advantage to a regular, original, traditional Medicare before treatment becomes necessary? And I think this is an interesting question because it's nuanced. It is best to make that decision between traditional Medicare and Medicare Advantage when you first become eligible for Medicare at least at age 65, if not earlier, from disability. Making that choice then allows you, if you chose traditional Medicare, to buy that Medigap policy in the way Kay just talked about, meaning that they're not going to penalize anyone for pre-existing conditions or age, meaning you didn't do it at 65, now you're 72. They may charge you more for that plan at 72. They may look at any of your pre-existing conditions, including your diagnosis. All of that is not included when they quote you a price for a Medigap policy right at the very beginning at age 65. So I would say the first point at which to make that decision is really critical because of that so-called penalty of what you may not get a Medigap policy later and all of that. So if that period of time has passed and you initially bought a Medicare Advantage plan and then are thinking, I'm still in watch and wait, maybe I should switch now, that we'll talk about in just a few minutes. And I think the slides will answer that question. Okay, now we're getting to Part D. So this is, again, pills, tablets, anything self-administered. That's what's covered with a Part D plan. And everyone who has Medicare is entitled to buy a Part D plan. You can, in Medicare Advantage, again, that's Part D is rolled up into your Medicare Advantage plan. And if you have traditional Medicare, then you buy a Part D plan. And if you want to know the acronyms when you buy it yourself, it is a PDP, prescription drug plan. If you buy it as part of Medicare Advantage, it's an MA PD plan. Remember, Medigap does not apply to Part D. So the plan is optional. This only started to become, Part D only really came around in early 2000s. Before that, there was no Medicare coverage for pills and tablets and self-injected products. Again, there will be a penalty if you join late, potentially because of your having waited. In both Medicare Advantage, or let's say in both PDP and MAPD plans, you are going to have formularies. So that's very different than the drugs in Part B, like Boy, which might be infused or injected in a doctor's office. So when you choose a plan to join, you will want to check the formularies. You will want to check what the covered drugs are that are available. In cancer, all plans are required to cover what they say are all or substantially all cancer drugs. But as we'll talk about later, it's not impossible to sneak around that. So it's really important to check carefully that all your drugs that you need today or may need in the future are on that formulary. After you have a monthly premium, that's what you pay to buy the plan. And after that, you have a deductible and co-payments. This year, you should have already noticed, if you were already on Medicare, that all your deductibles and co-pays cap out at $2,000. If it's $2,010, you are not responsible for the $10 anymore. You were in 2020, 21, 22, et cetera. But starting in 2025, it caps out at $2,000. And that's important because while we said that a Medigap policy does not help you for Part D, this new cap on out-of-pocket costs is potentially helpful. So in order to join Part D, and maybe we should have said this at the outset when we were having slides about should I get Part A, should I get Part B? Well, you have to have both of those in order to get a prescription drug plan or PDP to cover your pills and tablets. You similarly have to have it to get a Medicare Advantage plan. And of course, you have to have it to get any drug coverage at all. And as I have learned working with CLL Society, a number of our treatments are in fact covered under Part D. So it is important coverage for this community. Okay, so how do you choose a Part D plan? Well, if you're in traditional Medicare, there are plan finder supports and a program in your state, typically known as the SHIP program, that will help you compare programs. But in order to get started, highly recommend that you make a list of all your medications that you take now and look for a plan that gives you the best, most affordable access to those drugs. If you talk to someone at SHIP, they'll probably ask you for that, is to work with you on all your list of medications. In CLL, from what I've learned, you often are taking different treatments or combining treatments. And so just think ahead to whatever your doctor may want you to be doing or taking over the course of the year. There are a number of ways to join a Part D plan. There's phone numbers to call, websites to check. You can also do a paper enrollment. The hard part is choosing which plan to enroll in.
I think we have a couple questions that it may be good to catch up with right now. The deductible on original Medicare, how is that determined? It's embedded in the Social Security Act that it changes each year based on what they project to be both utilization and the cost of care. So they kind of look at their budget, I guess, and they raise it a certain amount, or if theoretically costs and utilization are projected to go down, it would decrease. And then we had another question on some at-home self-administered medications being covered under Part B rather than Part D. And that is absolutely typical of Medicare. Anytime Sarah or I tell you, this is how it goes, it's almost always got an asterisk where except for. So, and if we were to go into all of the except fors, we would be here probably for 3 or 4 days. So, yes, there are statutory self-administered drugs that are covered under Part B rather than Part D. It's in this, they're specifically listed in the statute. Also, if, for example, you were to have you need infusions and you have the drug drop shipped to your, your house or to an infusion provider and they infuse it at home, that's going to be not under Part B, but under Part D. So it's how it's dispensed and administered. So it has to satisfy both. It's dispensed in the physician office to the physician office and administered in the physician office or outpatient hospital center. If it's not, then it doesn't fit into Part B. It might be into Part D, and then things go from D to B based on from D to B based on statutory exceptions.
Yeah, I might say that statutory exceptions or the ones listed out in statute are not specific to CLL. And I haven't heard too much about any of the CLL drugs being dropped.
IgG. That was the
Oh,
question.
IgG, thank you.
Well,
Good exception. Yeah, I was thinking more about Imbruvica and Calquence and those, so thank you for that. So I think we just talked.
One more, if you,
Okay.
if you don't mind. The question about what happens to the state-by-state Medigap rules when you move to a different state. Well, that's kind of good news because if you move out of your, say you're in Medicare Advantage, if you move out of your state, then you're no longer able to be in that Medicare Advantage, and that gives you an automatic pass to go into fee-for-service or selected plan in that state. But once you're in that state, then that state's rules will apply thereafter. So
not to put you on the spot, Kay, but I'm not sure I know the answer to this question. If you move to a different state and you can now choose Medicare Advantage or traditional Medicare, that Medigap policy penalty of they may charge you more money or they may not issue you a plan, what happens to that?
Does not apply. That will not apply.
Okay.
So,
all right. So should I enroll in a Part D plan? I think the only time you may think about not doing so, I would imagine, is if you have what we spoke about briefly at the beginning, a creditable coverage somewhere else. So if for some reason your employer or an ex-employer like the federal government is covering your Part D drugs, your pills, tablets, self-injectables, with the exceptions Kay just outlined, if you're getting that paid for somewhere else, and it's like the kind of coverage you would get in Medicare, then there's no penalty for your sticking with your creditable coverage and enrolling in a Medicare Part D plan later when that coverage expires. Otherwise, yes, you should enroll in a Part D plan. Okay, we have another set of poll questions. So let's imagine that it's July. You enrolled in Medicare last year, but you did not enroll in a Medicare drug plan, meaning a Part D plan. Generally, when is your next chance to enroll in a Part D plan? During open enrollment, initial enrollment, your next birthday, 12 months after your initial enrollment. And the second question, you enrolled in Medicare last year, and you should just auto-enroll in the same plan this year if you were happy with it last year. True or false? Okay, once again, everyone is paying attention. The answer to the first one is correct, open enrollment period. Thank you. And in your second one, as I guessed, I should have waited I should have held this question until later. So the answer to this one is much more nuanced. And I would say the answer is false. Perhaps it had reason to be true for these past several years, but with all the changes in Medicare, especially in Part D, I'd like to suggest that the answer be false in this go-round, and we'll talk about why in just a few moments. Okay, Part C, Medicare Advantage. So we've sprinkled discussion of Medicare Advantage throughout the webinar so far. This is the opportunity. This is when you choose not to buy a Medigap policy to help you pay for your costs. You're picking a Medicare Advantage plan, which will include parts A, B, and D, inpatient, outpatient / physician office, and pills, tablets, self-injectables. So typically what we hear is someone is choosing a Medicare Advantage plan because it is cheaper than a traditional Medicare plan. And that has been borne out by lots of statistics. As the economy goes down, we tend to see a rise in Medicare Advantage enrollment, for example. It is another way to get Medicare coverage. It is run by private companies, and you have the important differences, and there are probably several, but one very important one is once you enroll in a Medicare Advantage plan, you have a network of doctors or hospitals. So in traditional Medicare, you see the doctor in the hospital that is relevant to you, important for you. You have a network you must choose from if you are in a Medicare Advantage plan. One thing some people have noticed is, for example, not all the comprehensive cancer centers are in the network for whichever plan you buy. So if you're going to go with Medicare Advantage, please not only check carefully about the formularies we just talked about, but also check what the network of doctors and hospitals is that will be available to you. And this will vary by plan. So take a look and see what Medicare Advantage plans are available to you where you live, and then compare them carefully. And while it is important to understand that historically, and probably still to this day and into next year, costs will be lower to you in a Medicare Advantage plan compared to Medicare, that comes with limitations on your doctors and limitations on your hospitals. And also don't forget the limitation in a different way of your ability to go back to traditional Medicare if, let's say, after a year or two, you have a new diagnosis you weren't expecting, or you just simply weren't happy with the network of doctors or hospitals and you want to go back to Medicare traditional, then that Medigap policy, for example, they don't have to issue you one, and they can use your pre-existing conditions, your age, etc., in deciding how much to charge you for that plan. Two important differences in choosing Medicare versus Medicare Advantage. So it's true that all the rights and protections of traditional Medicare are available to you. You will still have appeal mechanisms and ways to appeal your claim denials and whatnot. So that's true. You still get services that are covered by Part A and B, although they may be in a limited network of available hospitals and doctors. And yes, you'll have prescription drug coverage as well. Although be careful there as well. You want to make sure that the cost sharing and the benefits align and are similar to what you would have chosen if you had chosen a PDP instead of an MAPDP. And there are often extra benefits in a Medicare Advantage plan. Some of them will cover gym memberships or eyeglasses, or you name it. There's a variety of extra benefits. There's been recent attention and focus on these extra benefits. It seems unclear whether the health plans are well aware that people don't take advantage of them, even though they seem to like, it seems to be one of the reasons they choose a Medicare Advantage over traditional Medicare. And there's been a lot of back and forth as to whether a Medicare Advantage plan should have to, say, alert you 3 months before the year is over that you haven't used any of your extra benefits, for example, and some pushback on whether from plans as to whether they should have to do that or not. So this is really just a summary of what I already just explained, but just in the form of a side-by-side comparison. Let me see if there's something I should call out that I haven't yet. So I maybe will point out when it says on the left side, your supplemental coverage may pay your deductibles and coinsurance, that's referring to the Medigap policy. Also want to highlight that you have a choice of doctors and hospitals, whereas you have to stick with the network on the right-hand side. And I guess I didn't point out that you may also need a referral for a specialist if you choose Medicare Advantage on the right-hand side. We did get a question, which I will cover at the end, about vision dental to the extent that is covered in part in Medicare traditional and Medicare Advantage. I will talk about that at the very end, but I noted it here too. This is really just a completion of the thought in terms of comparison. I don't have any additional thoughts on original, but be aware that you likely have a monthly premium and copay or coinsurance in Medicare Advantage, but will not have a Medigap policy. You don't have the ability to buy a Medigap policy in Medicare Advantage like you do in traditional Medicare. But offsetting that, it is historically, as I said, cheaper to buy Medicare Advantage than a traditional Medicare plan. I want to highlight there have been recent investigations of the plans, the health plans that offer Medicare Advantage. Last year, there were investigations into the marketing of these plans to patients and whether that was whether the marketing was misleading or inappropriate or overly aggressive. This year, their focus has very much been on too much prior authorization, too much step therapy, all efforts to try to get you to, in my mind, give up and not get the treatment that the doctor wants you to have. Yes, there's a place for making sure the right patient has the right drug at the right time, but pushed to its limits, you are using prior auth, step therapy, et cetera, to really just deny patients care who might otherwise give up and not keep pursuing the hurdles to get the treatment that they need. I think for this, again, more of a comparator on what we've already discussed. So I don't think it's anything here that I have not already said. So maybe this is a good place to pause and Kay, take questions.
We had an interesting question from an individual who has Medicare and their secondary insurance is provided by a former employer once they retired. Now this former employer wants to, quote, switch secondary to Medicare Advantage. Does this make sense? Okay. What it appears that if you switch to a Medicare Advantage, then whatever promise they've made to you to continue covering your extra costs in Medicare go away, because they only, once you're in a Medicare Advantage, there's no supplemental. This employer policy is no longer on the hook for anything. So remember, if the Medicare Advantage doesn't ever end up being a secondary payer. So hopefully that answers. It's what they're asking you to do is switch from regular Medicare to Medicare Advantage. And when you do that, or if you do that, it saves them money.
But it doesn't necessarily help you as the employee. It's really important to appreciate that difference. You really have to do the math carefully on whether that's worth it financially, because in the long run, you have way more constrictions on the hospitals you can use, the doctors you can use, what medications you can take, how aggressive the efforts will be using prior authorization and step therapy to allow you to get the treatments you need or your doctor says you need, that sort of thing. That's a really difficult choice that employer is putting you in, because while they are there supporting you, they're asking you to make a choice that will cost you in the long run, potentially. That's a great question, timed perfectly to this slide of comparing and contrasting traditional Medicare with Medicare Advantage.
Wait a minute, Sarah, I got a question that I think you can handle here, or not you can't handle all of them. Summarize the differences between Medicare Advantage plans versus a Medigap policy, because it's still not coming through quite clearly.
Okay, so a Medigap policy is what you buy to supplement your Medicare Part B, like boy, coverage. So the Medigap policy is basically allowing you to offset what it's going to cost you out of your own pocket when Medicare Part B is working for you. So you're in a doctor's office, you're in a hospital outpatient department, you're in and out of the same day or the next day with a procedure, you walk into the emergency room. All of these things have a 20% coinsurance, for example. And the Medigap policy, if you buy one, will cover those costs for you. That has nothing to do with Part D, like David. Those costs are not helped by those out-of-pocket costs are not helped by a Medigap plan. If you get a Medicare Advantage plan, you also cannot buy a Medigap policy at all to help offset those costs. So think of Medicare, traditional Medicare and Medicare Advantage as your two choices. And if you choose traditional Medicare, Medigap helps you if you buy one. But the choice isn't Medigap or Medicare Advantage. The choice is traditional Medicare or Medicare Advantage.
And we had a question about what is Plan G and do I need it? So if you see a plan that's labeled by a letter, then what we're talking about is a Medigap plan. And the Medigap plans are kind of based on the letter, they cover a certain set of things. So Plan G is a very popular choice. It covers almost all of the costs associated with original Medicare, parts A and B, except for the deductible. It pays for the services after the Part B deductible, whatever coinsurance, as well as Part A hospital costs. And it covers the Part A deductible. And first 3 pints of blood, it also covers the hospice coinsurance. So it's a popular choice. It is a Medigap plan or a supplemental.
So relatedly, we had a question in advance that says, I have a Plan F, like Frank, and I'm a newly diagnosed patient with CLL. If and when I need treatment, what drug plan coverage will benefit me the most? Again, I think I want to separate or not conflate. Part F is a Medigap plan, and what Part D coverage you need is a separate question than Medigap. Medigap plans, if you buy a Medigap policy, it does not help you in any way with your Part D, like David, drug costs. Kay, would you add anything else to that?
No, I think that's good. And then we also had a question about if an insurer is no longer offering a specific Medicare Advantage plan, can you switch to original, or do you have to pick another one of that insurer's Advantage plans? If they're no longer offering the plan, you can do either. You can either go to fee for service or choose a different plan. And you can enroll in a Medigap if you choose to do so.
Right, poll question. Medicare Advantage plans help pay for gaps in original Medicare, cover less services than original Medicare, are private plans approved by each state, must cover all Part A and Part B services. So the correct answer is they must cover all Part A and Part B services. And the reason that's tricky is because We just finished talking about how traditional Medicare lets you choose any doctor, any hospital, but in a Medicare Advantage plan, you have a network of doctors and hospitals. So it almost sounds like they don't have to cover all the same services. But the careful thing to remember is the service might be the same. You may need a particular infusion, you may need a particular, you're allowed emergency room services under both, but where you go is what's different. You may need an infusion and may be able to get it, you will be able to get it in both, but what drug is infused or where it's infused may differ. So that's the way to think about it. It's the services must be the same, but you may not have access to the same doctors and hospitals for those services. So sometimes it's confusing because the people who answered that it covers less services than original Medicare, it is correct to say that it somehow offers you less than original Medicare. That's why you pay less, but it's not that it's less services. It's just different. It's less in the way I just described.
Yeah, there was a question that really gets to this. It was, do any networks for Medicare Advantage plans include major cancer centers? And the statistics on that aren't particularly great. 60% of MA plans don't offer access to any NCI designated centers. And 41% that are in an area like right next to an NCI designated center, even though they're in what should be their coverage area, they exclude them.
Yeah. That's really helpful. Thank you, Kay. So we've covered the entire alphabet soup of Medicare, right? We've talked about A and B and D, and we've talked about C, Medicare Advantage, and we've talked about Medigap. We often also get questions about the confusion between all of that and something called the health insurance marketplace. So Medicare is not part of the marketplace. It's really important to separate that away from when you are in the middle of open enrollment and you are thinking about what you're going to buy, traditional versus Medicare Advantage, this Part D plan versus that Part D plan, add a Medigap policy or not. Please do not be thinking at all about the marketplace. If you have Medicare or are getting Medicare for the first time, you're covered and you don't need anything to do with the marketplace. The marketplace is not related to all the Part D plans that are out there that you have choices from, or the different Medigap policies that are out there that you can choose from. None of that in any way relates to marketplace. In fact, it's against the law for someone who knows you have Medicare to try to sell you a marketplace plan. You don't need it, and you don't need to think about the vocabulary related to the marketplace and all that comes with that, really at all. Now, if you already had a marketplace plan before you joined Medicare, you may consider keeping it. But again, you don't need it. If you already have a Medicare plan, you don't have to go out there and shop for a marketplace plan. If you're signing up for Medicare during your initial enrollment period, meaning right at the beginning, you don't have to worry about marketplace again. I don't know if any finer point to put on that. It is the one place where we can try to take confusion and decision-making out of the mix for everyone. So I said at the beginning that in 2025, at the start of this year, you should have seen that for the first time ever, you had a limit on your out-of-pocket costs, not on the premium. Once you've paid the premium, then deductibles and co-pays and co-insurance, that's all capped at $2,000 a year this year. That was one way in which you felt better about not being able to buy a Medigap policy to help offset those costs. At least they were capped out. The other thing that happened this year that hopefully you all took advantage of, is that you had access to a new program, generally known as smoothing, which basically meant that if you signed up for this and you had to proactively sign up for it, you were allowed to spread those $2,000 of cost across the plan year. So if one prescription, let's say, cost you for an oral or otherwise self-injectable, et cetera, that you take at home, if that cost you $1,500 and in January or February, you didn't want to spend $1,500 all at once, you could spread that cost $1,500 across the rest of the year. And then you might have additional costs of another, this is a little bit of a trick question, another $1,500. How much of that are you responsible for? Only the first 500, because the first 1,500 and 500 add up to the 2,000. And you can spread that $2,000 worth of costs that you have to pay out of your own pocket across the whole plan year. That other $1,000 remaining from the second $1,500 prescription, you're not responsible for at all starting in 2025. So between the cap and smoothing, that should have offered some relief this year. Now, starting in 2026, if you did not proactively enroll in smoothing, you have another opportunity to do that in 2026. If you already did it in 2025, you will be automatically re-enrolled for 2026. What is new in 2026 also is that for the first time, cost of drugs that were negotiated, the price was negotiated as part by the government, included a drug called Imbruvica. 10 drugs for the first time ever will go on to formulary starting in 2026, whose price was negotiated by the federal government. The important thing to remember is that if a very high cost drug got their price negotiated down and now it's a mid-price drug, let's say, if you still pay out of your own pocket $1,500 or $2,000, you are capped at that amount. And it really doesn't matter to you in your pocketbook, that is, whether that drug's price is $500,000 or $200,000. Your pocketbook will only see $2,000 and then you'll have the cap. However, the implication of having the Imbruvica negotiated price on the formulary for the first time next year, there's a different implication. The government has been very strident with Part D plans to say, we took the time and trouble to negotiate down the price of this drug. You must make sure, United, Aetna, etc., that that drug, Imbruvica, is on the formulary. And they have made such a big deal about it that almost lost in the noise is the law from back in 2003, 2004, that said all or substantially all cancer drugs must be on formulary. So we may be looking at a scenario where United, Aetna, and the others feel some leeway in not ensuring that Brukinsa, Calquence, et cetera, are also on formulary. And it is this point that sort of created that question, the poll question that I wish I had asked now instead of earlier. If you were on a Part D plan in 2025 and you were happy with it, should you remain with it? Typically, the answers would have been yes, because it's hard to pick a Part D plan. There's lots of details. You have to make a list of your drugs. You have to make sure they're all on formulary. Well, and if you've done that once and you were happy in last year, why wouldn't you just leave it alone and re-enroll in the same plan? Well, it's for this reason, the first bullet on this slide. The fact that there is one negotiated drug in CLL now required to be on formulary, we are a little bit worried that the health plans will be less careful at making sure all the other CLL drugs are on formulary. So for the first time ever, I would say it is not okay to have been happy with last year's plan and just go with it again. take a careful look and make sure that all the other drugs that you want are still on formulary. And by the way, if you are also a diabetic, have cardiovascular issues, have any other things for which you take medications, Imbruvica was not the only drug negotiated. There were 9 others, and some of them were in these other categories I just mentioned. So please make sure that the formularies still for 2026, when open enrollment begins next month, that you make sure those other drugs that you've always been on are still there and available for you. Okay, you came on camera, so anything to add?
Did. Yeah, and on these formulary inclusions, sometimes the devil's in the details. So you will also want to look and see what types of controls they're putting on your access, utilization management. So are they prior authorization? You can expect that. But what if they have something like step therapy, so that you have to, for example, fail on Imbruvica in order to get one of the other BTK inhibitors? Is that, we don't know what's going to end up happening with these formularies and these utilization management tools once, you know, these negotiated prices go live. And I don't think CMS knows. I don't think anybody really knows what's going to happen. So that's another reason to kind of give a good check as you're looking to enroll this year, to see what types of controls are you going to be driving your clinician crazy trying to get you the drug that you're currently on. So and then there
And I would just
appears
add,
to still,
yeah, on your point, Kay, I want to just add that when you try to do that, when you try to do what Kay just suggested, you may see some language in the plan that is really hard for you to understand. It's hard for all of us to understand. Obfuscation is sort of part of the deal here. So I would say talk to your SHIP. We mentioned at the very beginning where to go for some help on choosing a plan, and your state does have resources to do that, and maybe you run it by them. And if the year begins and you find that these policies end up being more onerous than you expected, we hope you'll also let CLL Society know, because we ourselves are tracking, as Kay said, we don't know, the government doesn't know how these different policies will play out. And CLL Society is definitely here to help you, and to help us help you would be to hear from you that this is not what we expected. We read the plans carefully. We read the policies. This is not what we expected. And this is starting to happen to us for the first time this year. And the government will look to groups like ours for providing them this kind of information and insight. Sorry, Kay, go ahead.
well, there appears to still be some confusion on the interplay or lack of interplay between Medigap and Part D. And I think it's important to just kind of draw a really dark, really bright line between those two, because your Medigap is never going to touch your Part D. It doesn't cover any of the costs associated with, you know, Part D out-of-pocket payments. It doesn't pay any of that. It's only A and B. So it does get confusing because we've got all these different letters and all these different types of things that you can get. It's kind of like buying a car and getting the rust proofing or something. But it's real important to remember that Part D and Medigap don't have anything at all to do with each other. And on the idea of choosing a plan, a Part D plan, you could, for example, look and see you've got 2 different drug plans that appear to cover all of your drugs, and you can't tell which one is which one's better. When you go into your clinician's office, you might want to ask their billing people. So, is there one of these that you have a specific, you know, that you have a really difficult time with? If they're having a really difficult time, they'll be able to tell you. So, you know, that's another way of looking. And also, you know, throughout the year, if you're getting unexpected problems accessing these medications, you know, please share with CLL Society, so that because chances are it's not just you.
And if you don't yet know, if you're still on watch and wait and you don't yet know which drugs you'll be taking, I would either talk to my doctor, or I would make sure that the vast majority of them are available on formulary on the plan that you're taking. The other point I want to make is this year, you will also see on this slide that the out-of-pocket cap rises to 2,100. And someone asked a question about it's sort of on the both sides. Oftentimes, changing plans lets them save money. That may well be. This time, take a look at different plans, not just to help you save money, but also to make sure the drugs you need are on formulary. And that someone else commented that we have prices going up on Medigap policies. Please be aware that actually Part B and Part D premiums also may be higher this year. And those should be announced very shortly with open enrollment coming. So not only costs, but also formulary checks. And why I always worry when premiums are going up, because that creates sometimes a starker difference. Yes, we might see an increase in Medicare Advantage plans costs as well, but Medicare traditional may be a little higher. And so once again, we may see people shifting to Medicare Advantage. But when you have CLL, or when you don't yet know which treatments you're going to be on, or a cancer center that you want to go to nearby, those are really important things to take into account. Yes, I appreciate that you only have the luxury to take those into account if you can afford a Medicare plan, but check carefully the cost of the Medicare plan and the cost of a Medigap plan in deciding whether you really need financially to go to Medicare Advantage. Of course, we understand that Medicare Advantage is necessary for cost reasons for many people. Okay, so before we go to question and answer, and we'll start looking through the remaining questions that we have, we hope you got a better understanding of the differences between original Medicare and Medicare Advantage. If you heard a bias in what Kay and I said towards original Medicare, it's because we often hear from patients struggling to get to the hospital or doctor that they wish they could, and then paying a penalty for a Medigap policy later when they wouldn't have paid that upfront in terms of a higher cost to a Medigap policy. Understand the various parts of the Medicare program. We hope that comes clearer after this discussion today. So set Medigap aside. It is not part of the alphabet soup. It's additive after, right? First, you've got A, inpatient, B, outpatient, and D for drug. C wraps it all up in a bow for Medicare Advantage, should you need that financially. Completely separately is Medigap, which helps you offset your out-of-pocket costs on the traditional Medicare side. And then finally, you learned a little bit today about how to decide which parts of Medicare to participate in. So with that, I'll turn to the last slide, which I think is just Q&A. And Kay has done an amazing job going through most of them, but happy to try to answer some more here. So how do you enroll in smoothing for prescription costs? Kay, can you help us with that one? To enroll in the smoothing program, that's for Part D.
Okay, yeah, the smoothing program, you can enroll at any time, right? Now, each of your Part D plans will have a specific way of doing it. If you had high drug costs last year, chances are they sent you something in the mail about, hey, you look like you might be someone who could benefit, and they'll use language somewhat like that. And then they'll give you multiple ways of doing it. They don't yet have a way of doing it at the pharmacy counter, and that would be, particularly helpful. They're trying to think about how they can get that moving. But for right now, it's going to be doing it online, doing it paper, and doing it by phone. And I would suggest, if you're comfortable, to go ahead and do it online, because it'll be live, it'll be effective or whatever, much quicker, and you will know when it's effective as soon as it is. Same thing with telephone, but it might take you longer because you might have a wait. If you do it by paper, it's going to take longer to get the enrollment taken care of. And we all have heard about lost in the mail. Either your thing will get lost in the mail or whatever they send back to confirm that you've elected to participate in the smoothing program. And they're going to call it the Medicare Prescription Payment Plan, MPPP, not smoothing. So you could go on, if you wanted to find out how your particular, I'm going to say this, right now it's late in the year. I would be surprised if it would be particularly helpful now, as far as enrolling now. Usually it's most helpful if you enroll early. That way your $2,000 is kind of spread across the entirety of the year. Does that answer that for you, Saira?
Yeah, thank you. And relatedly, there's no harm in signing up for smoothing. As someone asked, if they don't expect to use it, no big deal. There's no downside to enrolling and not using it. So we have 12 minutes left. I want to see if I can answer as many of these questions correctly and quickly as I can. So there's a few comments I'll go through. I'll skip those and try to answer people's questions. If your CLL drug was covered in 2025 and it is not covered in your plan in 2026, you should either talk to your doctor about whether it's appropriate for you to switch, but more than likely, you just need to look for a new plan that will cover that drug. Beyond checking a provider's formulary, a provider, so you're checking a plan's formulary, not a provider. What is the best way to compare actual costs of various drugs that are covered? I'm not really sure what actual costs are, but the costs that you incur will be, I don't know how to answer this question. Kay, do you have a thought? Best way to compare actual costs of various.
We can go real simple.
Okay,
It
go.
used to be honestly, it used to be a big problem because people were on the hook for some portion of the cost for the entire year. It's a lot simpler now. Chances are if you're on, for example, a BTK inhibitor, you're going to hit your $2,000 one way or another, whichever drug you're on. So they're all, for you, going to cost the same.
Thank you.
I know that sounds crazy, but sometimes making things simple is okay. Some of them may have higher co-insurance percentages or whatever else, but the bottom line is whether they're, charging you 80% co-insurance, which they can't do. It doesn't matter. Your cap is at 2,000. So if they're going to,
That's great. Okay, if your income went down from 2024 to 2026, can you adjust it? No, it will take 2 years to adjust. There are no cost caps in original Medicare Part A and Part B, correct? That is correct. The cap of $2,000 we're talking about, or $2,100 starting next year, applies to Part D Medicare. Okay, is there a nuance you would add to that? Or can I keep going? Okay. Yes, it does not matter whether it's zanubrutinib or another drug. Your out-of-pocket costs, as long as it's is a oral or self-injectable drug covered under Part D, yes, the cap remains $2,100 for next year. Can you tell in advance what your actual out-of-pocket costs will be? Well, you know what the cap will be. The cap will be $2,000. But if in the middle of the year, the doctor prescribes you a medicine for your diabetes or your flu or your, I don't know what, no, it's really hard to know if you're going to be under $2,100 next year, what exactly that cost will be.
I think we've gotten a couple questions about TRICARE for Life and Part D.
I haven't come across those at all yet. So why don't you answer that while I go on?
If you have TRICARE for Life gives you basically a Part D plan, and it doesn't have a cost associated with it. So it's what they call creditable coverage. If you ever decide that you want to get a Part D plan, no penalty, no matter how late you enroll. But keep in mind, your TRICARE for Life pharmacy benefit is the same as a Part D plan. So you do not need a Part D to separately enroll in Part D.
Okay. Okay, I'm going to keep going, but maybe you can help answer this one. And then I'll continue to flesh out the others. If you turn 65 in November of 26, will you have to meet the annual drug out-of-pocket costs for the 2 months in 26 and then start over in 2027? In other
Yes.
words, does meeting your out-of-pocket cost in COBRA help you? No, meeting it in COBRA does not. Okay, that was easier than I thought. Is my spouse's income included for my Medicare premium? No, Medicare is individual to you. For example, if you are in Medicare, unless you're filing jointly, I'm sorry, I'm not a tax expert, so I really can't say. Kay, do you have a thought on that?
Yeah, goodness, that's in the weeds, but we can answer that separately. I believe that
No,
it's
I think we really
family
have to ask you
income
to
if
talk
you,
to a
yeah.
tax attorney about that. Yeah, we can't, I'm afraid it would be difficult for us to answer that. If you originally bought your MA plan from an agent, do you need to maintain that relationship to make changes? No, you do not. You should not have to use an agent at all if you don't want to.
We did have a question about someone who says they did not enroll in a medical plan, meaning Medicare Advantage or Medicare Part B. I believe that's what they mean, due to cost and another employee plan. Now I don't think I can get it due to pre-existing condition. Medicare does not have pre-existing condition issues. The question that you're going to have is whether the insurance that you have, the employer-sponsored insurance, is creditable coverage. So you want to talk to your employer and find out, and that will you'll still be able to enroll in Medicare. Medicare will never tell you, oh no, you have a pre-existing condition. You may end up having a penalty for enrolling late if your insurance from the employer was not what they call creditable coverage.
If you enrolled in a Medicare Advantage plan, is it possible to change to original Medicare? Yes, but you may have difficulty getting a Medigap policy to help you with those costs in the ways we discussed today. Okay, you covered that one, Kay. If you're on watch and wait and don't know what you will need till the future, is it a better choice choosing between traditional and Medicare Advantage? Again, switching back to traditional Medicare comes with a penalty. So if possible, try to do it right at the outset, if it's financially feasible. Okay, I think you ordered the... We have 5 minutes left. I feel like I'm racing across the clock.
Let's see. Oh, again, the clinical trials.
Oh, yes. Why don't you do the clinical trials one?
Okay. And we had a question that gives very, very good information on Medicare and clinical trials, which is that Medicare will cover the routine care costs associated with clinical trials. They encourage Medicare beneficiaries to enroll in clinical trials. Medicare Advantage is supposed to pay for clinical trials, but here's the catch: if the site, if the investigator and the clinical trial site is not within your Medicare Advantage network, that's where the rubber hits the road. And for example, if you have MD Anderson, as this question pointed out, they only allow some Texas Advantage plans. If you have one of the others, then your Medicare coverage of the routine care costs is not going to kick in. Now, can you enroll in a clinical trial anyway? I would find out. I would talk to, the payment from Medicare is of benefit to clinical trial sponsors because it reduces their costs. So if you want to participate in a clinical trial, I would talk to the investigators, talk to your clinician.
I think we're realizing from all these questions that there's a great deal of pent-up demand for answers. And so I'm so glad we held this webinar. And please keep your questions coming. If there's another webinar we can do or put into our calendars, we'll certainly look to do that and try to continue to answer your questions. I want to make sure we get the slides back up on the screen. We would like to once again thank our generous donors to CLL Society and grant support from AstraZeneca, B1, and Genentech for making this event possible. Thank you all for joining us today. And please remember to complete the event survey and provide your feedback to help CLL Society plan for future events. This webinar was recorded and will be available on our website along with the slide deck. If your question was not answered today, please resend your question to support@cllsociety.org. We will do our best to get to answering as many as we can. Join CLL Society for their next webinar, Protecting Against Infections When Your Immunity is Impaired. And that one will take place on October 14th. And then finally, please remember CLL Society is invested in your long life, and you can invest in the long life of CLL Society by supporting our work. Thank you so much.